Okay, I'm going to take you through filtration here. This is the toughest part of this chapter. That tutorial up at the top, it's a link. Great interactive tutorial. I highly recommend it. Okay, so down here at the bottom right, you see a blood vessel, which is in tan. You can see the little fenestrations that allow things through it. Then you see in pink surrounding it one of the podocytes, they make up the visceral layer of the Bowman's capsule. That's the internal layer of the Bowman's capsule. So if little materials can pass through the fenestrations of the blood vessel, and those little things can then pass through the little slits, the sieve of the podocytes, then they're now out in the Bowman's capsule. And then it's filtrate. That's what it is. Okay, so let me go on. Important definition for glomerular filtration rate: amount of plasma formed by all the nephrons per minute based on surface area. In other words, how many nephrons, if they are functional, if they're damaged, that sort of stuff. The permeability of the filtration membrane, that is right there at the blood vessel, at the glomerular wall, Bowman's capsule podocyte area, is the integrity of the wall good enough of the two together that things can pass easily across? If there's inflammation, it decreases permeability or infection. And 3, the net filtration pressure. We're going to talk about that right now. Okay.
All right, I apologize. I'm really sorry. I apologize.
All right. Let me get rid of sound here. Okay. So here we are at net filtration pressure. Really important to understand this. 3 pressures. You've seen a couple of them already. Blood hydrostatic pressure, also called glomerular blood hydrostatic pressure, GBHP or just BHP. It is the pressure in the blood vessel pushing outward. If you look at this picture right down here, it is the purple arrow that you see here. It's the outward force. And that outward force is, at least on theirs, let me make this smaller, they're saying around 55. It's not important to know that number, but just keep it in mind. Okay, so that's actually the major force in making filtrate. The stuff gets pushed out into the Bowman's capsule container. Okay, now there are 2 inward forces that are trying to keep plasma in the blood, that are trying to pull water back out of the filtrate, back into the blood. And they are BCOP, blood colloid osmotic pressure. It's the exact same thing as what we covered in capillary dynamics. It is the brown arrow that you see here, and this picture says it's about 30. So you can see that the osmotic pressure, again determined by albumins from the liver, is not as strong an inward force pulling fluid in as the outward force of the hydrostatic pressure pushing the fluid out. But there's another force, and that is capsular hydrostatic pressure. So let me change colors here. Now, as the fluid, okay, so you already know that the outward flow force is 55 and the inward force is 30. So there's an overall outward push. All right. So the plasma, I make it in blue dots here, starts collecting inside the capsule as it gets moved across. And as more and more fluid accumulates, now some of it, of course, is just going to go down the proximal convoluted tubule, but a lot of it starts collecting in this capsule, and that causes a pressure increase out here in the capsule. And that's the capsular hydrostatic pressure. And as that CHP increases, it's pushing against the plasma trying to come out because of the hydrostatic pressure pushing it out. So if you add these two together, they are a pulling inward force, keeping plasma in, and they're balanced against the glomerular blood hydrostatic pressure, force out. So if you add those two together and you minus it, subtract it from glomerular hydrostatic pressure, you've got the overall number, right? That's net filtration pressure. So down here I've given you some sample numbers just again to get you to understand this. If you add the two inward forces trying to pull plasma in, you get 45. Your outward pressure is 55. That means you still have an outward force of 10. There's still going to be production and leakage of plasma accumulation out there in the capsule. Now, you can see that there are things that could mess this up easily. If the pressure drops, if the glomerular hydrostatic pressure drops, let's say from 55, let's say you have extremely low blood pressure, and that would cause a drop in your glomerular hydrostatic pressure, and let's say it drops to 40, okay? So if instead of 55 you get 40, and remember that the inward force is 45, what's going to happen? You're not going to be making any filtrate. You're not going to be making any urine. So obviously blood pressure can have an effect. The other thing that can happen is you could have a change in blood osmotic pressure. Remember, albumins, they come from the liver. Let me get rid of some of this stuff here. Okay. So if for some reason your albumins are not being made properly from the liver damage, I don't know, and instead of 30, it's only 15. So now you got 15 but 15, and that equals 30. But your outward force is 55, and remember, it was supposed to be 45, okay? You're going to have a heck of a lot more plasma now leaking out when it should not. All right? So, net filtration pressure, really important. Okay. So, some things that vary filtration. Okay, the first one just talked about. Okay, so let me get to these other three. There are three. Autoregulation, sympathetic autonomic system, renin-angiotensin pathway. Let me go with... trying to see what I want to do here. I think we'll go with sympathetic first. Yeah, that's where we'll go. Okay, so that's pretty easy. Remember I mentioned before that this system only has sympathetic input. Alright, so you know the neurotransmitters epinephrine. I mentioned also that there's the afferent arteriole carrying blood into the glomerulus and nephron, and there's the efferent. And the afferent has a wider diameter, and so there's more blood going in than coming out, and that keeps the glomerular pressure high. Alright. However, if the afferent arteriole is constricted, it's going to reduce blood flow into that glomerulus, and that's going to drop the glomerular hydrostatic pressure. The neurotransmitter is obviously epinephrine here, and when you reduce glomerular pressure, you're going to drop the net filtration rate. It's going to become lower because there's less of a force outward and less urine's going to make it. In other words, blood's going to be conserved in the body. Not blood, water. Sorry. Okay, so that's an easy one. Alright, let's go autoregulation. Alright, so let's say that your general arterial blood pressure goes up. And remember, if your glomerular hydrostatic pressure is a little bit different number than your overall arterial pressure. If you were really high blood pressure, I don't know, 180 over 160, if that pressure translated into glomerular hydrostatic pressure, which is too high, that would really damage the kidneys. It's like driving 18-wheelers into your cul-de-sac. Remember I used a cul-de-sac with houses around it as to mimic a glomerulus. So, when your arterial blood pressure rises, your glomerular filtration rate would potentially rise because you've got more outward force of the glomerular hydrostatic pressure. So what happens now is the nephron fluid flow goes up, okay, because the GFR has gone up. This then now is going to signal, because remember, this is bad. We don't want this to happen. So we're going to reverse it, and we're going to do it by the macula densa, which remember is in the DCT, right there where the distal convoluted tubule comes in contact with the afferent arteriole bringing blood in to the glomerulus. There's the glomerulus. And here's the efferent arteriole bringing blood out. Where they meet, right here, there's the JG apparatus, and this inner wall of the DCT is called the macula densa, and it now releases a chemical which is going to cause the afferent arteriole to become constricted, and that means now you get less blood flow to the glomerulus, and if you drop that blood flow, then your GFR decreases, and therefore the kidneys won't be damaged by high blood pressure. Okay, are we good? Okay, next. Renin. Okay, let me remind you. Comes from the JG apparatus, the JG cells, right there where I just mentioned. The stimulus has to do with how much stretch there is in the afferent arteriole, which is of course related to the pressure, right? Overall blood pressure could affect your glomerular hydrostatic blood pressure, causing it to go too high. So we don't necessarily want your glomerular blood pressure to go sky high if your regular pressure does. Or if your pressure drops. Let's go drop. If your blood pressure drops, that could conceivably drop your glomerular hydrostatic pressure, and you wouldn't be clearing blood sufficiently. So we don't want that happening. Alright, so if your blood pressure goes down, general blood pressure, then remember that's going to mean less flow via the renal arteries and, to the kidney, and eventually there's less blood going in the afferent arteriole to the glomerulus. Alright? So, if there's less flow because of less pressure, that means that the afferent arteriole is not stretched nicely tight, you know, like it's full of blood. It's more, I don't want to say collapsed, but it's just not, the flow is down. So, you know, it's like a little stream that's, well, the stream's now since we're in a drought. But anyway, okay, so as a result of that, a drop in arterial pressure right here and a drop in glomerular hydrostatic pressure. Here we go with the JG cells and the macula densa. They produce renin. It goes out into your blood. The renin acts on a hormone that came from your liver. It's called angiotensinogen. Comes from the liver. I'm just going to abbreviate it. And that angiotensinogen will eventually be activated to angiotensin II. I'll talk about that in more detail in a minute. And remember, this is a powerful vasoconstrictor. And so now we get efferent arteriolar resistance. So you got, remember you had a drop in flow in the afferent, but now that we constrict the efferent, then that means there's going to be more flow going in the afferent. And also remember that angiotensin also is a general vasoconstrictor. It gets your blood pressure, your overall blood pressure up. So the overall effect now is glomerular filtration pressure goes up, and everything is good again. Life is good. Okay, so here's a look again at what happens. Whoops, didn't mean to go that far. All right. Okay, so again, remember renin production from the JG cells due to a drop in blood pressure in that glomerular area. The angiotensinogen coming from the liver, it's converted to angiotensin, okay, by the presence of renin. Now we have angiotensin 1. Angiotensin 1 is not very functional. It has to get converted to angiotensin 2, and there's an enzyme that does it. It comes from the lungs. It's called angiotensin converting enzyme. It converts angiotensin 1 to angiotensin 2, and that's the important angiotensin right there. Okay, so what it does then is vasoconstriction, higher blood pressure, signals adrenals, they make aldosterone, this causes sodium retention, that causes water retention, and all these things together get your blood pressure up, which restores your blood flow in the afferent arteriole back to the kidneys, and life is good again. Now, here's a really important point. I put it in pink. Your kidney is only supposed to make renin when there's a drop in blood pressure to itself. If your kidney is making renin for no damn good reason, the blood pressure is normal, and it spazzes out, and it starts making renin, then you've got renal hypertension. You've got hypertension, high blood pressure, that is caused by the kidney going berserk and making renin when it should not make it. And a lot of people have that problem. So again, here's a look at what's going on. You can stop this and look at it, blah, blah, blah. Notice the hormones here. There's the renin. There's the aldosterone that I mentioned earlier. I didn't mention ADH, but also angiotensin 2 also stimulates ADH coming from the posterior pituitary that releases it. You know, remember it comes from the hypothalamus. And again, ADH causes water retention. So any way you want to look at it, you get a raise in blood pressure. Okay, so onward to reabsorption. Okay, this is going to happen in the proximal convoluted tubule, 90% of it. Okay, so you're looking at the PCT. Notice, yellow, by the way, is the lumen. Okay, so here's where your urine is, in here. These are the simple cuboidal cells with microvilli, or let me call it brush border, that makes up the walls of the tubules. Here is a PCT right there. Look at the DCT here, and you will notice that the DCT has a very, I don't know how to put this, defined inner lumen where the cells meet the lumen where the urine is. The PCT has a much like fuzzier kind of area here. That's because brush border. So again, if we were looking at a DCT over here, you wouldn't see brush border. It would just be plain old simple cuboidal cells, no brush border. Okay, so what you see going on here is a heck of a lot of movement. Here's your blood vessel down here at the bottom. Again, urine is up here in this thing. Alright, so where shall we start here? Alright, let's just start with things we need to reabsorb. Remember, reabsorption, we're going to move the important stuff back into the blood. We don't want it to go out in the urine, so we're moving stuff from tubule back into the blood. Okay, so let's start with sodium. Okay, so you see some sodium right in here. And look at the arrows going this way. We're going to move it from the urine, the tubule, across the tubule wall back into the blood to conserve sodium. And notice that there is a little red protein carrier right there. I'm pointing to it. And notice what else is coming along with the sodium. As sodium goes that way and then ultimately moves into the blood, The glucose is going hand in hand. This is called co-transport, and they move together. Sodium and glucose going through life together. Okay, so there's one. Now, what else shall we move across? Okay, look over here. You've seen this God knows how many times now. Carbon dioxide. These cells make CO2. Remember, these simple Kubota cells are metabolizing. They make CO2. The CO2 combines with water in the cell, 70% of the cell. It becomes carbonic acid. Carbonic acid is unstable, becomes bicarbonate, breaks down also to hydrogen. Bicarbonate moves into the blood, and where's my chlorine? Well, actually, we're only talking about moving stuff into the blood, but you'd have a chloride shift. You'll see that later. The chloride is coming from the blood into the cell. Okay, well, anyway. All right, what else is important here? Oh, hydrogen. Let's talk about it. So the hydrogen, look at this hydrogen right over here. Now, remember, this could cause pH problems in the tubule cells. So we are going to, one of the things a kidney can do is it can manipulate the hydrogen. It can either move hydrogen this way into the blood, or it can move hydrogen out this way into the lumen, depending on what the blood pH is. So we're going to talk more about this in a minute, but the kidney can control blood pH. We actually are going to talk about that in the next chapter too. Okay, let's go back. Alright, so I've taken you through co-transport and countertransport, showing you a couple of things. Mainly co-transport, sodium and glucose, and amino acids move across. Sodium pulls some other ions with it. Passive transport, some anions. Water, of course, is moving by osmosis. Renal thresholds, I've shown you this picture before back in metabolism. Remember that you got to have carriers to get the glucose to come out of the filtrate back over into the blood. There has to be carriers, protein carriers, in the cell membrane of the simple columnar cells. And how much glucose is brought back in depends on the carrier. Every glucose molecule has to be attached to a carrier. So, there's only a finite number of carriers. And if you've got a ton of glucose in the blood, and it all gets ended up in filtrate, as you know, because it all gets filtered out, then there's not enough carrier molecules to bring the glucose back in, and only some of it will get back in, and some of it stays out in urine. Now, you should be ahead of me by now and thinking about diabetes, because this is what happens in diabetes. Your blood glucose is so high, and the blood glucose gets filtered out, and it all ends up in the filtrate, but then a bunch of it gets carried back into the blood via the carriers, protein carriers in the simple columnar membranes. But a bunch of the glucose without carriers can't go anywhere. It has to stay in the filtrate, and it ends up going out in the urine, which is why diabetics have sugar in their urine. That's renal threshold level, and it's right around 180. Anything, when your blood glucose is over 180, there's just not enough carriers to get all that glucose back. Okay, let's talk about waste. There are some things that don't get reabsorbed. Creatinine. So let me remind you, you covered this in 24.1. Think about creatine. My thing is writing slow. Creatine phosphate. You talked about it in muscle. Creatine phosphate is a high energy molecule. There's a high energy bond right there. And if this bond is broken, that phosphate gets stuck on ADP, and the two of these together make ATP. It's one of the ways your cells gets really fast energy for muscle. What you have left, this part of it right here, becomes creatinine. Creatinine is all gotten rid of. Your body doesn't want to keep any creatinine. It wants to get rid of it. Get out, get out, urine. All right, now there are a couple other things here. Uric acid and urea. These are all nitrogenous waste products, usually associated with protein use. Some of the uric acid is reabsorbed because you actually carry around a lot of uric acid in your blood, but again, not too much, and some goes out in urine. Urea, you might think that all urea goes out, but no, quite a bit of it stays in your blood. In fact, there's a value that they run on you all the time. I'm sure you've had it done. It's called the Bunn test, blood urea nitrogen. It's got to fall within a range. I don't know what the range is, like 4 to 15 or something like that. It can't be too low. It can't be too high. If it's too high, it indicates kidney problems. Okay, here's a reminder of a couple things talked about before. Alright, so here's that line of delineation between medulla below and cortex above. And remember, there are a couple of blood vessels right over here, which are the borderline. They're called the arcuate arteries and veins. They'd be sitting right there. Two kinds of nephrons. Cortical nephron, juxtamedullary nephron. We're now going to be turning to the juxtamedullary nephron because it's really important in salt and water conservation. Okay, this is the tough thing. Countercurrent multiplier process, and then we'll stop. Okay. There's no easy way to do this, baby. Let me get the big picture. Look at this picture right over here. Medulla, down here in orange. Cortex, up here in light tan. You see the nephron in white. What we are going to do, what your kidneys are going to do, is your kidneys are going to concentrate salt. And I'm going to make salt as blue dots. And the deeper into the medulla we go, deep being that's the medulla, we're going to go down into the medulla, the more salt will be concentrated. Okay, so lots. My blue dots are salt. Salt everywhere. And by the way, I'm talking sodium. Na. Alright, so we've got a ton of sodium concentrated here, a little bit less up in here, okay? So what we're doing is we're making a sodium gradient, all right? As you go downward, more salt. Sodium. Now, the reason for doing that is sodium is a powerful osmotic molecule for water, to draw water out. So we are setting up an osmotic gradient of sodium to draw water out of the nephron so that all the water doesn't go out in your urine. So in other words, the countercurrent multiplier mechanism is a concentration of sodium in the medulla of the kidneys so that we can draw water out to follow it, remove it from the urine so you're not losing lots of water. Now, why is this important? If you're dehydrated or you're losing blood, you do not want to be losing bunches of urine. Urine is mainly water. In those situations, you want to conserve water. And that's where this countercurrent multiplier mechanism becomes really important. It allows you to do that. Now, to understand this, you need to understand the loop of Henle now. So, let me change colors. And let's go to yellow for filtrate. Okay, so here's my filtrate up in here. I'm going down what's called the descending limb. Okay, descending limb. And notice that the descending limb, there's some blue arrows. Those blue arrows mean that water can go out. Okay, so the water's going out into the surrounding tissue of the medulla, following sodium, right? Okay. Now, I should also tell you that sodium cannot get out in that descending limb. It's stuck. Alright, so the sodium, remember there's some sodium not all the sodium gets moved out into your medulla. Some is still in the filtrate. Okay, so the water is moving out, and look at the little black dots. That's actually supposed to be sodium. I'm going to get rid of that. Okay. So as water moves out, water moving out, the sodium is becoming more concentrated. Remember my glass of water with a little bit of salt, and you leave it out in the heat, and at the end of the day, it's saltier. You haven't added any sodium. You just lost water. Well, that's what's going on here. So this becomes more saltier. We're talking about in the tubule. But now we go up the ascending loop and things change. Because in this area, water can't get out, but the sodium can. Look at those little red dots right there. Sodium is leaving. Sodium is leaving. So again, remember, sodium, let me go back to little blue dots. Sodium is now accumulating out here. Okay, now remember the water can't get out over here. So now the water, the urine, goes out the DCT and ends up in a collecting duct. Now we're still going to have one more place where we might be able to control some water. You see some little blue arrows, but they have dotted lines. We'll talk more about that coming up. But there's a last little place where we might be able to drag some more water out. Okay, so this only happens in the juxtamedullary nephrons. Okay, let me show you the next view. We're going to talk about this more in lecture because it's a tough topic for people. But I want to go back one more place. Okay, so you're thinking to yourself maybe, whoops, didn't want to do that either. Okay, so you're thinking to yourself, well, there's all this salt down here. Isn't that high salt going to do damage to the kidney tissue? Well, it could. But we're going to get rid of it here in a second. Okay, so we've got all this high salt. And remember, we also have a ton of water out here that's followed the salt. Okay, so let's talk about what's going to happen here. Look at this blood vessel. Remember the vasa recta? It's those real deep, loopy blood vessels down below the peritubular capillaries. You only find them in the juxtamedullary nephrons. So here's a loop. So now what's going to happen is the sodium out here, little blue dots, are going to move into this vasa recta, by diffusion. High salt out there, low salt in the blood vessel, moves into the blood vessel. What's going to follow it? Water. Water moves in. The flow carries the extra salt and the water away and out of the kidneys back to your general circulation. Sweet. Okay, onward. Okay. I'm going to stop there. I think you've been overloaded enough.